Good afternoon, and a warm welcome to Season 2 of our talk show series, Let's Talk Primary Healthcare. It was a great honor for me to launch and host our series last year and to see the growing interest to connect regularly about primary healthcare policy and practice. We discussed so many interesting topics last year about the ongoing transformation of primary healthcare in the pandemic and post-pandemic context. We talked about how to respond to growing demand, how to set priorities, how to reorganize responsibilities and tasks, while being mindful that task shifting does not become task dumping. We talked about reaching the vulnerable, and we talked about how to support our most precious resource, the health and care workforce. If you are interested in looking at any of our previous episodes, you can find them at the YouTube channel of the WHO Regional Office for Europe. We launched our second season with a burning issue: how to respond better to the dramatic increase in mental health issues in our communities. What is the role of primary healthcare? How can we remain intentional and smart about scaling up these services, taking into account our constraints? What barriers might we encounter and how to overcome them? I am sure that you have similar questions as I do about this very important topic, and let's hope that our discussion today will bring us closer to some of the answers. We will start with a one-hour panel discussion. After this panel, I will invite you to join us into 2 deep dive sessions where we will take these topics forward and consider them for 2 special populations: adolescents in Deep Dive Session 1 and older people in Deep Dive Session 2. We invite you to come and join us to express your experience in those sessions. In the meantime, please use our chat, say hello to us, give us your comments and your questions, and my colleagues will be also sharing important resources with you as we go along. With this background, I would now like to welcome our panel, and I will introduce them to you all. Abiel Avrebo will be the voice of practice in our talk show today. She's a nurse practitioner advisor in Drammen Municipality in Norway. Dr. Jonathan Campion, Director for Public Mental Health and consultant psychiatrist at South London and Maudsley NHS Foundation Trust in the United Kingdom. Dr. Peter Winkler is Director of the National Institute of Mental Health and the WHO Collaborating Center for Public Mental Health Research and Service Development in Czechia. And Dr. Ledia Lazari is Regional Advisor for Mental Health at the WHO Regional Office for Europe. A big welcome to you all. Thank you for taking the time to join us to share your thoughts about this very important topic. And let's get immediately started with our round 1 of discussion: useful strategies to scale up mental health services in primary healthcare settings. And let's start with the voice of practice. Abiel, you're a nurse practitioner. What strategies have been implemented in your practice to scale up mental health services?
Hello, it's a pleasure to be here. Thank you for having me. I would first like to confirm that in Norway there has been an increased national focus on mental health care in general, but the challenge is bringing about real change in the foundational levels of healthcare, as in primary healthcare. And I work in geriatric healthcare, and we see a huge lack of competency within mental health in our area. So, and at the same time, we also see a large increase of patients with these issues, and we don't exactly know how to meet these issues. It's only when these issues are very large and they cause extra problems that we take notice, and then we realize that we have to do something, but we don't know how. So a lot of nurses who experience patients with mental health issues might become unsure of themselves, and they might remove themselves from the situation rather than meet the patient where they are. One of the things that we are doing in my municipality is trying to increase competencies on all levels in primary health care. And we are, for example, using a national course created by a national agency focused on geriatric healthcare. And these courses are very easy to follow and very easy to understand. And they're based on literature that the participants read about the information on their own, and then they join for reflection together. And we feel that this reflection encourages attitude change. And then in turn, this will encourage change in practice. It's really easy for us to ask doctors to prescribe medication for our patients instead of using time. And we need to learn to recognize the right signs, and we need to learn how to meet our patients in the right way. And I'd also like to mention that we've seen an improvement with more involvement of specialized healthcare professionals in primary healthcare. And recently in our municipality, we've had hospital doctors come and educate our community healthcare workers. And we've also had patients in nursing homes, for example, receive assessments and short-term follow-up from hospital doctors. And when this has happened, we've received guidance and advice. And this approach gives us a unique opportunity to learn from these specialists, which in turn helps another patient the next time around. So we would like to see this evolve to a deeper commitment, making it easier and quicker to get help from specialists.
Thank you, Abiel. I think there was a lot in there to increase competencies through training, to strengthen the collaboration between primary healthcare and specialists. And I loved what you said about valuing time and time spent differently. That was wonderful. Jonathan, I will come now to you. You have had a unique career pathway to work as a GP and then a psychiatrist. And now you are advising and leading regional and global work on mental health policy. What do you think are some of the most promising strategies to scale up mental health services in primary healthcare settings?
Thank you. I'm delighted to be with you all. Yes, I first worked as a GP before moving to psychiatry. And while working as a GP, I was so struck by the very large proportion of consultations with important mental health elements and opportunities. And in the UK, mental health conditions affect 1 in 4 of us each year. So that's every family. So it's such a huge area of opportunity. And we've got evidence-based interventions to treat, prevent, and promote mental health. But there's a huge implementation gap, as we know, both for treatment, but even more so for more upstream interventions. And that gap varies very widely across the 53 countries of the European region. And even within those countries, there's very wide inequalities. But we've got this exciting opportunity, I think spurred on by the UN Sustainable Development Goal of universal coverage by 2030. So in terms of promising strategies to scale up in primary care, I think the first is to look at the size of the implementation gap at country, regional, practice level. And that's a good starting point, I think, so that different sectors can move in a coordinated and stepped approach to achieve this 2030 target. And I'll come back to that. In terms of other strategies to scale up, I think there's a lack of mental health skills. And certainly that was my experience as a GP, even in training. I'd done psychiatry before, and GPs were very keen in my practice that I saw all the people with mental health conditions. So there's something about clearly a need for a much greater level of undergraduate and postgraduate training. And I think also in terms of prevention and promotion, that needs to be better represented. Training can be delivered in various ways, including online, the WHO's mental health gap program, for instance, but it also requires to be in primary care rather than secondary care relevant. A second barrier is the lack of resource and staff, which drives extremely short consultation times. And that really requires, I think, an important sort of actions to address. We can think about task shifting. You referred to the danger of task dumping, but that is an opportunity. I think other promising strategies to scale up, integration and coordination with other sectors, such as secondary mental health care, schools, voluntary sector. A fourth is improving population mental health literacy and supporting self-management, including through digital technology, which also supports reduction of stigma. And I think the last but by no means least is the co-creation with patients and carers, so that actually we have a very sustainable model going forward.
Thank you very much. I think these are very powerful approaches and strategies, and we will return to some of them. I'll just pick on the first point you mentioned, and I want to emphasize that when we look at the role of primary healthcare in delivering mental health services, this is indeed in an ecosystem of a variety of partners, both governmental and non-governmental, who deliver very valuable services. So this mapping, identifying the gaps and how to bridge them is indeed a very critical step to move forward. Peter, let me come to you now. You have led mental health reforms at the national level. What would be your take on this question on successful strategies, and what can our region learn from the example of Czechia?
Yes, thank you for this question, and I will follow up on Jonathan. And as a health economist by background, I'm always trying to look at things from the demand and supply side. And Jonathan spoke a lot about supply side, about what needs to be done with services, with better coordination, with better training. And I'm going to emphasize the demand side, which is the population that is in need. And what we know is that in mental health, there is a huge treatment gap. The data from the Czech Republic speaks about 60% treatment gap for depression, 70% for anxiety disorders, and above 90% for alcohol use disorders. In the same time, if people look for help, it's mostly GPs where they turn most often. And those who are not willing to seek care or do not seek care are those who are not able to consider themselves as having mental health problems, those who have large stigma, and those who don't know where to get professional treatment. So there is a clear need to, on the one hand, work towards mental health literacy of the population. Because if you look at the WHO pyramid of mental health care, it starts from the self-care and it goes to the informal care. And this is exactly what is mental health literacy about. It's the ability to obtain and maintain good mental health, to have positive attitudes to those who have mental health problems, to seek care effectively, and to understand the mental disorders and their treatment. So we basically need to increase mental health literacy in the population, so the population is able to better take care for themselves, better take care there for the close ones, and seek help effectively when they need it. But what this implies, if we do it, this will hugely increase the demand on the other layer of the pyramid, which is primary health care. So we need to work with the strategies, some of them were already mentioned, in order to make it sure that this demand is met successfully. And we need a better coordination, we need lots of strategies, and that's probably another round of the talks that we will need to speak about today.
Thank you very much. I think that's really a great addition, that you shifted our focus to the demand side, to the people's perspective. We will pick this up a little bit later, but indeed, if we're successful at creating demand, it's imperative that we meet that demand. We see in many countries that primary healthcare has grown so successfully to manage NCDs and multimorbidity that demand has increased even faster, and primary healthcare is often the victim of its own success in that sense, and we have to build strategies that avoid that or build that in or address that specifically. Lydia, let's continue our first round with your perspective. You have line of sight over the 53 countries that make up the WHO European region. From this regional perspective, which strategies would you emphasize? And considering the diversity we're encountering, what do you think we need to be mindful of when we consider scale-up approaches?
Indeed, thank you. Thank you, Melita, and good morning, good afternoon to all participants, and thank you for having me here. I'll take it from the last comment you made, considering the diversity. The WHO Regional Office for Europe covers for a very diverse region that represents not only a myriad of different good practices, but also a myriad of various financing and mental health service organization models. And that brings us to the discussion, why do we at all need mental health into primary health care? So why is the purpose? And someone that is especially living in a reality with less specialized mental health resources, might become even cynical and say that, well, integrating mental health in primary health care, we need it because we do not have sufficient specialized mental health resources. But actually, the truth why we need the integration of mental health into primary health care is because the primary health care is the substratum where the continuity of care is secured. This is the key word in any mental health service organization. The key word is ensuring continuity of care. And if we do not have mental health care in the game, we will have gaps, and the people who will need mental health services will fall into the cracks and the gaps of fragmented systems. So primary health care would be like the liaison to all, would be the enzyme that ferments care. In addition to what the colleague said, I would also try to mention, and probably it wasn't touched upon, but the lack of also policy frameworks. We have, where the countries have progressed with integrating mental health into primary health care, it has started with a demand, of course, but also the response has been to first set up policies that allow primary health care workers to take upon mental health care, but also then to get the skills, the necessary skills and competencies, and to be given the roles and responsibilities that they need. So I would start by saying that one of the strategies is to formalize and to legitimize mental health care integration into primary health care through policies. The second is that no matter how much we try to upscale mental health into primary health care, unless we have good and solid specialized mental health services, we'll not be able, because then what might happen is, imagine a situation when we have very good primary health care workers that have managed to go to talk to the community, have earned the trust of the community, and have addressed the stigma that is in community about asking for help for mental health care. And then the moment that people reach out to mental health care, then there is not solid specialized mental health services when those are needed. So I suppose we should talk both from the side of the demand, but also of the offer. So it is not enough to simply encourage the demand from the population and the demand at the primary health care, but it's also equally important to solidify, to strengthen, and to amplify the response from the specialized mental health care services. And last, if you will allow me 30 seconds, is the importance of strengthening roles and responsibilities of mental health, of primary health care, should also include the skill mix. So how can we think of inclusion of mental health professionals into the primary health care teams, such as psychologists and social workers, for instance? And with this, I give the floor over to you. Thank you.
Yes, thank you. I think that was a really great overview, and what a rich discussion we have had over a short period of time. I have listed for myself nearly 10 strategies that we can work with parallel or together or combine in some way. First, just to give a quick summary, make sure we invest in public health and prevention to begin with at community level. Second, if you think of service delivery strategies, capacity building, training, enhancing competencies, very important approach. Expanding teams, perhaps towards multidisciplinary teams with the addition of mental health professionals to primary healthcare teams, with a redefinition of roles and tasks on that team. There has been good strategies proposed related to the integration and collaboration between primary healthcare and specialists, and the parallel strengthening of the different levels of care to retain a balance, and then partnering with community organizations and working in partnerships. This is only on the supply side, and we are also encouraged to look on the demand side to work together with people, enhance health literacy, encourage appropriate care-seeking behavior, and so on and so forth. These strategies can make a real difference in people's lives. And now I would like to invite you to watch with me a 2-minute video where we look at how shifting care to the community level has impacted on Julie's life who has struggled with mental health issues for a while.
Ik ben Julie en ik ben 39 jaar. Ja, dat is zo'n groot woord, psychische kwetsbaarheid, maar eigenlijk ben ik ook maar gewoon mens met mijn ziek zijn. Ja, je ziet het niet aan mij wat ik heb, dat brengt soms problemen mee. Dan weet ik bijvoorbeeld ook soms voor dingen dat ik niet weet waarom. En is het leven soms heel lastig voor mij. De laatste poging dat ik geprobeerd heb was in 2017. Maar ja, ik zit kijk, met een dochter en een man en ja, ik zit kijk, nu stabiel genoeg om dat niet meer te proberen. Verschillende periodes heb ik daar opgenomen geweest in het Heilige Hart. Met verschillende tussenpauzes. Ja, vanaf 2009 is dat eigenlijk veel begonnen van geregelde opnames te hebben. Maar de langste periode dat ik gehad heb was ongeveer 6 maanden een stuk. Toen was Helena nog redelijk klein en ja, is dan bij mijn moeder opgevangen geweest. Dat was echt wel de hel dat ik dan naar huis niet kon. Ja, dat was wel een heel zware periode in ons leven. Het was een zwarte periode in ons leven, in ons gezin. 6 jaar geleden ben ik gestart met het mobiel team. Ik heb dus ja, toch ook meer te zeggen over mijn eigen dossier precies. Ja. Zo van, we overleggen ook meer dan bijvoorbeeld ja, in de kliniek is dat meer boven je hoofd dat alles gaat. De artsen en de verpleegsters onder elkaar zo, terwijl nu kan ik ook open kaart spelen, volledig open kaart spelen en houden ze ook wel echt rekening met de wensen van bijvoorbeeld bij een opname wordt er gezorgd dat er niet te zwaar wordt. Ja, dat ook voor de dochter en voor mijn man opgevangen wordt en zo. Er zit ja, een...
Julie's story and our discussions so far have been very inspiring. But can Julie's story become everybody's reality in our region? We know the reality on the ground, and we may all anticipate some barriers when we talk about scaling up mental health services in primary care setting. So in our second round, let's consider these barriers and let's also consider some strategies how we may overcome them. And Jonathan, I would like to start with you. What are some of the barriers, the most severe ones that we might anticipate on this journey?
Thank you. Yes, I mean, I think as mentioned before, I think mental health skills in the workforce is certainly one, and that can be addressed, I think, at undergraduate, postgraduate level to reflect the huge impact of mental health conditions and also the impact of mental well-being and resilience across populations. Various ways to deliver that to doctors and nurses, including digital mental health gap. I think the outreach from secondary mental health care, as mentioned by Lydia, is also very important as support. But I think in terms of we need to recognise also the overload of the workforce. I remember when I did my membership exam for primary care, I had 20 minutes for each patient for my exam, and then I went to 7.5 minutes per patient the next day. And there's something about time, and although the workforce is very stretched, as I mentioned at the beginning, and as Petter mentioned, only a minority of people with a mental health condition receive treatment, with far less coverage of the more upstream interventions, even in higher income countries. So I think there's a need to think about resource and staff, as mentioned, coordination and integration with other professional groups such as psychologists, but also other sectors such as secondary mental health care, but also thinking about schools, workplace, community organisations. We've mentioned task shifting, but also coming back to staff and in this overload, the need to prevent burnout of existing staff, as well as early recognition and treatment of mental health conditions in primary care staff. They're a higher risk group. And I think the last area is this lack of awareness of the size of the implementation gap at country level, district level, and practice level. And that's compounded by poor data. And so we need to be thinking strategically, a whole system approach, working with other sectors such as public health to assess the gap relevant to primary care, and thinking about a systemized approach to providing information about coverage and outcomes of different public mental health interventions, including to higher risk groups. And then coming back to the stepped approaches to address the barriers to achieve the goal of universal coverage by 2030. And this requires transparent decisions about acceptable levels of coverage going along these steps with other sectors, but also required resource. And I think the system then is enabled to monitor the progress about the coverage and outcomes of different interventions. And that's very much supported by a collaborative approach with local stakeholders.
Indeed, those are very significant barriers. Abia, let's reflect on barriers from the perspective of practice. And as you mentioned, nurses play a very important role in addressing mental health issues, perhaps as part of multidisciplinary teams. What barriers have you faced in attempting to provide more mental health services to your patients?
I have to confirm what Jonathan is saying, because I think one of the major barriers for nurses is time. Nurses are running around trying to do so many things at the same time. They're putting out fires instead of preventing them. We've seen that central health authorities, they're responsible for hospitals, and they've reduced capacity, which we've talked about. And this has pushed a large burden onto the community healthcare, primary healthcare, and it's overloaded, like you said. And this hasn't really been successful because we've had the policies up on top that have said that this is how we're going to do things, and then they haven't given enough resources down at the bottom, if we can put it in that sense. I think that we have to have that. We have to value time in a different way. And in Norway, we have this saying among us nurses that nurses are potatoes. Just like potatoes can be used in many different ways, in many different dishes, so nurses can be used in different roles and to do different tasks. And through the years, one of the strategies that has been tried to make a more efficient healthcare is to reduce support staff and then give these responsibilities to the nurses, and that's further increased their workload. And so nurses, they do all sorts of different things, like dusting a patient's room. In Norway, at least, they clean beds between patients, and they cook and prepare meals in community healthcare, as well as putting in IVs and giving shots. And I think that we need to have a renewed task optimization. I think this is very important in primary healthcare, that we need to have the right people doing the right things, that nurses should be doing nursing jobs, and other people can take care of other issues. And I wouldn't consider it a task dumping, because I think that it's important that nurses really can use their training in a better way. And I think that you don't need to have a certain training to dust a patient's room or clean beds. Other people can do these things that don't have the education. We need to use our training. We need to maximize the use of our training and really use it for patients' benefit. Another problem that we have in society in general is that everything is sped up. We're running fast to get done with all our practical tasks. Nurses are really busy, and we forget that patients really need to be seen. I've experienced that many times myself, that patients, they see nurses coming in and putting in the IV and giving the medication, and then they leave right away sometimes without even asking, how are you? How was your day? I think this is like a basic thing that has sort of disappeared in nursing throughout the years because of this problem with time. And I think that what we need to do is we need to create a space for nurses to be able to have conversations with patients. We need to value this conversation, value it as a therapeutic intervention, because this will be preventive. This is preventive medicine that nurses should be doing. That if you catch things earlier on and you use time to meet them, then you might prevent problems later on. And so I think that another thing is that this conversation that we have, it's like that things are sped up, people are running around, and when they see someone sitting down talking bedside, then they think they're not working, that they're not doing anything. And I think that in nursing, we need to really strengthen this and say that, you know what, we need to put this in our care plans. We need to have this as an active part of our care plans, and we need to document the conversations as well and record them and use them in a helpful way for our patients. So time is a large issue. And another issue that has been raised several times is a lack of knowledge for mental health, and it's within the mental health care workers, or in the primary health care workers. But it's also in our community, like others have said. And I think that many people struggle to recognize the problems and they don't know how to speak about them. So many people think that depression and anxiety are just the normal part of aging. But we know that mental health issues play a large role in, for example, rehabilitation potential. And we have issues like dementia that magnify mental health issues because they have a decreasing ability to mask their symptoms. So we have all these issues. And one thing that we have to remember is that somatic and mental health are intertwined. And we often forget that because we often split these up into two different things. And we say that, okay, if you're in a hospital, you deal with somatic problems, and then you have a different area that's psychiatric or mental health issues. And I think that one way to meet this barrier of people being able to talk about it is talking about the stigma, is removing it, and is normalizing mental health. And we need to inform our public about symptoms and inform them that this isn't normal. You can get help. We can treat in this way or that way. And then people will be more willing to actually reach out for help, and then be it psychological or medicinal, then they would get what they need.
Thank you, Abia. That was extremely powerful and very rich. And I like where you ended up. And this gives the unique vantage point of primary healthcare, that it is the only actor in the system that can provide a holistic approach to people as a whole, and not in a fragmented manner to each of their diseases or health conditions. And that is the holy grail, to transform our service delivery at primary healthcare level towards this more holistic, people-centered approach. So thank you for these barriers. And I like very much that you didn't only list barriers, but immediately some strategies of how to overcome them and what to be mindful of. With that, let me come to you, Lydia, to complete our ever-growing list of barriers from the regional perspective.
Thank you. It's extremely interesting, actually, also to listen to Abiel that has a first-hand experience happening now. And I would like to take from what you said, Abiel. You talked about how frustrating, and sorry if I'm putting the word frustrating in your mouth, you probably didn't say that, but you mentioned how there is an underutilization of nursing skills because of tasks that may be taken care by other unqualified workers. And this brings me to the set of roles and responsibilities that we assign, the health service management assigns to staff, which does not necessarily reflect the skills and competencies they have been receiving. Why this is important, it's not only to avoid frustration at an individual level, but it's also to prevent that people disconnect from their work, and that people also leave their work. What we know now in Europe, for instance, is that we are facing an alarming hemorrhage of the mental health workforce, very, very pronounced among the mental health nurses. And I assume part of that, it's not only linked to how much people are paid, but it's also linked to the prestige and the value that the system assigns to their profession and to the exertion of their tasks, skills and competencies. So I'll go back to what I said before, that the roles and responsibilities are the blurred roles and responsibilities are one of the barriers, and this needs to be addressed through policies and, of course, training, as Jonathan mentioned again. I would like to focus a bit on the stigma. Abiel also ended her speech by focusing on stigma, and I'd like to draw our attention that as we are here, a large community of health professionals in this room, and I can see who is coming, they're representing various even practices or institutes. And I think we should be aware that we should not think of stigma as something in them. I think all of us as a global community are also carrying stigma in one way or in another to different extents. And it's because of stigma. Stigma is also a very important barrier when, for instance, financing is decided, how much we assign funds to a mental health service depends very much on also what the policymakers think of mental health. Do they think that people with mental health conditions are gone for good? That there is no hope for them, that, oh, whatever you do, it's because this is a lot of, most of the time, many people think that once affected by a mental health condition, you are stuck there. So this kind of misunderstandings, myths, prejudices, stigma, and therefore discrimination is a very strong barrier in not only designing mental health services, but also in resource allocation, in training, etc. So all the things that stem from there. So I think stigma is a major barrier. And again, a call that we should not see stigma as us, that are the experts or the policymakers, and them. Stigma is something that is ingrained so much in every level of society that it's a barrier we need to name, accept, and therefore address.
Thank you, Lydia, for that. And indeed, this is the foundation of our ability to strengthen mental health services in primary healthcare. Peter, now it's your turn to add to our list of barriers. And in particular, in your remarks, if you could focus a little bit on an important strategy, which is, you mentioned earlier, primary healthcare can partner with community organizations, NGOs, private organizations, to deliver jointly mental health services. That's a very important game changer. But of course, this is not straightforward. This is not easy. How do you see the implementation barriers and strategies to overcome, particularly for this approach?
Yes, thank you for this question. I think this is really important, and it goes back to the basic question, which is how do we use available resources effectively? And Abiel spoke about doing right people doing right things in right time, and Lydia spoke about underutilizations of skills of some people. And this is really what is it all about. And it's not just on a level of mental health care workers or general practitioners. It's also on a level of services. And partnering with community organizations, it includes resources that we might not at the first sight think of. For instance, in the Czech Republic, we have a network of about 200 low-threshold clubs for youth at risk. Those people have usually mental health needs which are not met. And people who are working in those low-threshold clubs are usually social workers which have some kind of basic psychotherapy training. It's very easy to meet a lot of needs just by using these resources, by training those who work in these low-threshold clubs to recognize symptoms, to provide some low-resource, evidence-based interventions such as behavioral activation, and to refer people to right services if they see they might have some psychiatric needs, for instance. But we need to think outside of the box and think about all of these resources and how do we coordinate them. And then if we start to think about this, and this might include many other different examples. Jonathan mentioned schools and workplaces. This is exactly where these kind of things needs to be done: screening, promotion, prevention, and coordination. But it's also in the emergency situation. For instance, with COVID, we used psychologists who are working in army or in police to provide mental health care to the general population or to people who need it. And this is exactly how to use available resources from many different sides. And to do that effectively, what you need is a strong leadership and strong coordination. And it's not realistic to expect that general practitioners or some members of the primary healthcare system will be able to do it. This is a responsibility of local governments, of municipalities, and other governing bodies to ensure that all these resources are coordinated effectively. And we just need to think about burden of mental health problems on one side, which has been mentioned in prevalence. We could speak about economic aspects of that. We could speak about life years lost or disability-adjusted life years and these kind of things. But we also need to speak about stigma, as Lydia mentioned, because if you think about it, really what it means and what is going on in the society today, it's very similar to what has been going on in society 100 years ago in relation to babies dying during the birth or shortly after. Everyone thought it's kind of a normal. And now lots of people think that it's kind of a normal to spend the decades of their life in depression. And the burden is such that many people actually are going through this. So we need to get out of this and accept the true burden of mental disorders and to mobilize all the resources that are there in the society to meet this demand. And this is the only way how the WHO pyramid of mental health care can really work. Because if we miss one layer of that pyramid, then we immediately create huge pressure on the other layer of the pyramid. So we need to think outside of this box, and we need to ensure that there is a strong leadership on the level of local governments, communities, municipalities, and that there is a efficient and timely coordination of all the available resources.
Indeed, I think that's a very important point, and it's critical to emphasize that even though we're digging deep into primary healthcare related strategies, we must view this as part of this larger ecosystem and not forget about the rest. Activation of municipalities and local governments to engage in health and well-being support is really critical for the success of many of these strategies. This has been a very powerful round. We put together indeed quite a few barriers, and I will not attempt to make a detailed summary because it is the details you provided that were so beautiful. But we talked about the lack of resources in multiple dimensions as a key barrier. I very much like that you went beyond the usual suspects and emphasized lack of data, lack of information, lack of analysis as one of the barriers. Lack of resources in terms of financial resources is a big issue. And of course, financial resources have to translate to human resources, as I mentioned earlier, our most precious resource. And nearly all of you reflected on that. And of course, time as a resource. And we will come back to that question in a moment. Maybe the second list or sub-list of barriers would be about how we are organizing healthcare services today, both at primary healthcare level, but at secondary cares as well. And movement towards that holistic approach, multidisciplinary approach, is really where we can make an impact with an appropriate optimization and rethinking of tasks for the conditions that we have to face with in the coming decade and in the volume that is already indicating that's going to be difficult to meet. And the third barrier, I will just re-emphasize that to make sure it's on all of our list, is to be able to address stigma and discrimination, which underlies the success of all of our policies. All of you mentioned the issue of time, overload in primary health care. And we know that even prior to the pandemic, primary healthcare faced a high workload in many cases, difficulties to retain staff, especially in remote and rural areas. And we are now talking about further expansion of the scope of work, further expansion of the workload. This is going to be a real challenge, isn't it? How can we meet this challenge? Let's do a quick tour de table with each of you reflecting on the same question. Lydia, starting with you. What are your top 3 tips to address these constraints?
Thank you. Thank you, Melita. And I think I think we need to be very comprehensive into addressing those constraints, because very good efforts have been there all along by many countries in many contexts to address the barriers, the challenges that are in a given context. But then in order to address them once and for all, those need to be addressed in a comprehensive way that starts with frameworks that should make sure that not only policies are in place, policies and legislation is in place, because in some contexts, we also have legal constraints to primary health care for getting involved into delivering mental health care. And starting from that, you cannot even dream of providing training and capacity building to primary health care workers. And that's why we need to start with the overall frameworks that should allow primary healthcare, should enable, should empower primary healthcare to be part of a very well-oiled and functioning system. So policy and legislative frameworks is one. And from that, then it will stem the need for capacity building training, as Jonathan said, even during training and education, but also postgraduate training to add skills, etc. And that will allow also the redefinition of roles and responsibilities at the right level. And that by defining roles and responsibilities, it will allow this will allow inclusion of other professional profiles into the primary healthcare teams. And I mentioned briefly before, like psychologists and social workers. This will allow also the redefinition of the roles and responsibilities of the primary healthcare as such, as a unit, as a service delivery unit, because we are talking about roles and responsibilities of individuals within the team. But then will the primary healthcare team have the task of promoting mental health? Will we expect primary care doctors and nurses to talk about positive mental health, to talk about hygiene, sleep hygiene, etc.? Will they have the time to do that? So all these questions will stem from how will they be regulated and how will they be positioned within the map of the systems. And of course, one more thing that I would like to be very strongly advocating for is, no matter what actions are taken, unless financing is improved, both in the way how existing funds are used, so optimization of existing funds, but also investing more in mental health, which means allowing also investment to go to mental health into primary health care. And this is a must. Let's not kid ourselves. It's not only about shifting the existing resources, but it's paying for more. If we want a healthy population, we need to invest for a healthy population. And in WHO's words, health is wealth. So I would be a very strong advocate for that. Thank you.
Very, very powerful words, Lydia. Thank you very much. Peter.
Yes, so my 3 points. I would just like to emphasize what Lydia said with resources, and I would like to emphasize the need to use the resources from many different sources, actually. Let's not speak just about health insurance or healthcare resources, but because it's also schools that need to invest in prevention and promotion. It's also workplaces that need to invest in prevention and promotion, so businesses. And we need to utilize these resources from all the different sides, because mental health is not just a subject of healthcare. It's usually ministries of labor, ministries of social affairs, ministries of youth education and sport, ministries of justice are as well involved, and they should be all contributing into the system so it's financed properly. Obviously, effective coordination of these resources is needed. Otherwise, we will end up in fragmented care where these resources are not used effectively. And the third, we need a proper training, actually. And proper training not just for people who are in primary healthcare, which is a must, but also for all medical doctors, for instance. Because we know very well that people who develop physical illnesses, especially some of them, such as oncological illnesses, they are very prone to develop mental health illnesses too. And we need all medical health workers to be aware of these issues and be able to recognize them, screen them, and refer people effectively. The training needs to go to teachers, the trainings needs to go to managers who work in businesses. Basically, the mental health is such an important part of our life that everyone should be educated in that sufficiently and correspondingly to his or her role in the society. And for this, mental health literacy is just a must.
Indeed, thank you very much. Jonathan, let's bring you in on this one.
Yes, no, thank you. I think certainly population assessment of current unmet need, both for treatment, but also prevention and promotion, and how to reach universal coverage by 2030. I've said that several times, but this really needs to inform policy and then transparent decisions about what is acceptable coverage for these evidence-based interventions. And then that informs the required investment, as Lydia has highlighted, and to add that many of these interventions result in economic benefits across different sectors, even in the short term. And so a population assessment also supports an integrated and coordinated approach with a broad range of sectors, which also helps them support, achieve their policy objectives. And I think, so there's a huge opportunity here. There's something, this is kind of more strategic, but there's also something at a more local level, practical things that can be done and are required. So I think training we've highlighted, and also these opportunities to support with a broader range of sectors, even now to start this process. Peter was giving some very good examples.
Indeed, and Abia, let's close this round with your perspective. How can we overcome this time barrier and use our resources better?
Yeah, I'd like to just comment really quickly about how, on a foundational level of healthcare, it seems like to me that policymakers don't look far enough down the line. I think that if they were to meet it earlier with investment, like Lydia said, in preventive healthcare, then you would help further down the line. Because I work in geriatrics, I see the result of patients who have lived a long life with issues not being met earlier on. So I think this needs to be addressed, and it needs to be invested in, and you need to realize the value of it. You might not see financial benefits, because in Norway, at least, everyone's very into seeing the financial benefits. You won't see that in the short term, but you'll see it in the long term, and it's kind of hard to document. So over time, we have to use this or look at this. And then I also think that there's an underutilization of, for example, nurse practitioners, especially in Norway. I think in several European countries, it's a rather new role. And I think that we also have staff with more competencies in mental health, but they're not being used for mental health because we have so many other issues that we have to take care of, the basic issues. And so I think that if we could have a focus on using the different roles purposefully to optimize their tasks, we would be able to cover a whole lot of needs in our communities.
Those are very helpful approaches indeed, and very good thoughts. We have now come to our very final round, where I would like to look into the future with you. And let's end our talk show with some messages of optimism and inspiration. But I have to give you a very difficult task of fitting into a 45-second elevator speech, each of you. And Peter, let's start with you. You're going to demonstrate how to do this. You have all kept wonderfully to time. It is me and my editorialization that got us tight on time at the end. You have achieved so much in Czechia. What is the frontier for you, and how to get there in the coming decade?
Yes, thank you. To me, the most important thing and the most important factor for my optimism is that I see more and more people realize the extent to which their personal happiness, their ability to live in relationships, in the community, contribute to the society, is dependent on how do they really feel. It's dependent on their own mental health rather than on the property they have or the amount of money that they have on their financial account. I see many more people seeing how important mental health is, and this will drive a change in my mind.
Thank you. Abiel, your turn. What is your ask as a nurse and on behalf of nurse practitioners to policymakers to make this a reality in the future?
Well, we've mentioned this many times, and I'll try to be very quick because I have actually 4 points, but I have to cut them down. The first thing is, of course, training that needs to be incorporated in the workplace, not dependent on people getting their training outside of their work, because people, well, in Norway, we have a big focus on our free time, and so then it doesn't happen. So it needs to be incorporated in our workplace, and stakeholders need to be investing in this. We also need better connections between specialized healthcare and primary healthcare. Nurses should be able to call someone for advice in specialized healthcare without having to go through the doctor. When we work at a nursing home, we don't see the doctor every day. We might have issues that we need to seek advice. So there needs to be a better flow in patient care. And also an ambulance psychiatric team is something that we really, really would like to have in the community healthcare. It would address this gap and help communication between the different health services. And the one thing I want to end with is that we see a clear divide between, like I said earlier, between mental and somatic healthcare. And I think that if we are to admit that mental and somatic healthcare are intertwined, why are medical records so separate? At least in Norway, it's that way. Why is it that it's so hard to find out what is going on with that patient in the mental aspect? It's a secret. And how can we nurses create a holistic care plan for patients without the information that we need to do this? And in this fact that they're so separate and so secretive in a way from us regular nurses, the society and the medical system is underbuilding that stigma. They're saying that this is a need to be secretive. This is something that we don't want to talk about among ourselves. And so I think that we need to work on making this flow more smoothly and letting us all know what is going on with our patients so we can get that holistic healthcare, and we have to have more openness. And remember, this is one thing I want to end with, is that we have to get through to the point that everyone has a mental health. Everyone. And it needs to be made clear in our societies and in our medical healthcare.
Indeed, those are very good reminders. Jonathan, your words of optimism and inspiration.
A fantastic opportunity, really, to see primary care as a central partner of this opportunity to adopt a local and national population approach to both treatment, prevention and promotion to support the achievement of universal coverage in a coordinated and collaborative way. Data systems can support both assessment and monitoring to close the implementation gap. Training absolutely vital, and the co-creation with patients, carers, the general population and stakeholders, because as you say, it affects us all. Thank you.
And Lydia, you will have the last word. Tell us about WHO's efforts to support countries on this journey, and how can the Mental Health Coalition help?
I'm very happy to see in this meeting today many of those who attended the meeting of the regional consultation meeting we had 2 weeks ago, again as an online meeting. This was a meeting aiming at introducing the European Framework for Action on Mental Health and identifying what are the working packages. We had a very interactive meeting through Slido and chat interaction, and what we learned, what our partners want us to focus on is working on leadership packages and working on transformation of mental health services, in addition to other topics, but those were the two champions of what our partners, our member states want to do. And this is, we are starting working together immediately. That means that everybody in this room is invited to contribute to the development of the working packages that will be taken care of by the Mental Health Coalition, and certainly within the framework framework of transformation of mental health services, strengthening mental health into primary healthcare, mainstreaming mental health into primary healthcare is the key strategy to transform mental health services, along with deinstitutionalization, building community care, mental health care, and so on. So this is a call to everybody that has applied to become part of the Mental Health Coalition. Join us to work together, the working package that will make better mental health into primary health care for all in Europe.
Thank you very much. And indeed, we from the WHO Regional Office for Europe are committed to working on this issue and to bring you more policy guidance, evidence, inspiring country stories how to do this. With this, I want to thank our panelists for your insights, for the strategies you have highlighted, the success stories, the barriers, and also for your words of inspiration. And now we would like to hear from you all. We invite you to 2 deep dive sessions to take the conversation forward. In deep dive session 1, we will consider adolescents. In deep dive session 2, we will consider older people and how primary healthcare can work better to address their mental health needs in a holistic way. My colleagues are pasting the links to the chat, how to join these rooms. Please do so. When you close the main window, there will be a survey popping up that's asking you how you felt about this talk show. Please take the 20 seconds it's required to answer it. It will provide us with very helpful insights how to do better in the future. I look forward to seeing you in the deep dives, to hear your voice and your experiences, and I definitely look forward to seeing you next time in our next talk show. Have a good afternoon.